vitiligo is an autoimmune disease. Like that is the destruction of melanocytes leading to appearance of depigmented macules, and then this is just not a skin disease. It's a disease which affects the psychology of the patient very much, which has to be borne in mind. So vitiligo is very common. You see around 0.5 to 4% in the general population. It's very the prevalence is higher in states of Gujarat and Rajasthan, where it's around 9%. When a person has vitiligo, there is a high chance that the family members were also affected. So maybe around 30 to 40%. Onset of the disease is at the age of like 10 to 30 years of age, and the prevalence increases with the increase in age. Patients usually present with appearance of depigmented macules in the acral areas, namely knuckles, fingers, eyes, mouth, feet, and genitalia. As the disease progresses, it can lead to a stage where near total depigmentation of the body occurs. Signs of disease activity, you all know that pruritus, increase in the size of the lesion, appearance of satellite lesions, scallop margins, and then appearance of cubinization phenomenon. All this point towards active disease. So coming to the pathogenesis, this is a flow chart which tells you about all the hypotheses in vitiligo pathogenesis. So to the extreme right, you can see the autoimmunity theory, which is the most accepted and most commonly cited etiology for vitiligo, but there is no single particular cause of vitiligo, so that has to be kept in mind. So the treatment varies accordingly, and you try to hit different hypotheses with different molecules so that you get have different drugs in your armamentarium that helps to cure vitiligo as a whole, treat vitiligo as a whole. The neurologic hypothesis tells you that when there is a decrease in neurotransmitters, there is loss of dendricity, and then leads to weakening of melanocyte attachment, and then detachment leading to apoptosis and trans-epidermal elimination of melanocyte. At the same time, this process can be initiated by loss of growth factors. This hypothesis is called growth factor reduction hypothesis. And then there are other causes like genetic and viral causes, which are explained by appearance of clinical lesions like zoster-form herpes. All this lead to loss of melanocytes, and then leads to the appearance of clinical vitiligo and subclinical vitiligo. The types of vitiligo, clinical classification, you have two types, segmental and non-segmental, and then unclassified vitiligo. This becomes very useful while you choose the treatment modality, and then it also helps you to have an idea like what type the patient presents with, and over the period of the disease course, the subtypes can change accordingly. So acrofacial, mucosal, more than one side, generalized, mixed variant is both segmental and non-segmental. And then there are zoster-form vitiligo, which is not mentioned here. And then segmental vitiligo, it can be uni, bi, or plurisegmental. And classified vitiligo, focal and mucosal. Symptoms of vitiligo, patches can be hypopigmented or depigmented. Depigmented is more classical. There can be appearance of white hairs or premature graying of hairs in patients. So whenever a patient presents with premature graying, always examine the scalp for depigmented macule in the scalp. Don't forget that. And then coming to the treatment options, there are different treatment options. The most commonly used drugs, topical steroids, topical calcineurin inhibitors, and then physical therapy and surgical therapy. As I told you earlier, each of the so each drug each disease actually hits a different part of the pathogenesis hypothesis. So topical steroids and topical calcineurin inhibitors, they're more they hit the autoimmune hypothesis part, and then when you come to the decapeptide molecule, it hits the growth factor deficiency hypothesis. Physical therapies include ultraviolet B, UVB, UVA, and laser therapy. Surgical treatment, it can be grafts which are taken from a pigmented area in a patient, and then it is autologously transferred to the depigmented macule. Each has its own side effects. Prolonged use of topical steroids can cause skin atrophy, striate telangiectasia, and then acneiform lesions, and then prolonged use of the common side effects of surgical treatment can be scar formation at the donor site and cobblestoning at the site of the recipient site. Other modalities which are used, camouflage technique is used to hide the depigmented area, and when the patient has almost near total depigmentation, it's ideal to remove the existing pigment, which leads to irreversible depigmentation with MVEH. Always the psychological component of the disease has to be assessed, should never be missed, because most of the patients, they still face social stigma. Unless you talk to them about it, they're not going to open up. I have seen people still being treated like an alien in the home, like separated, they're given separate vessels, separate area in a house, and then once I questioned her, how are you, is it affecting your mental health? She broke down immediately. So if you're not asking this question, you may miss this. I have seen patients with depression also. Vitiligo with depression. It was just a 2 x 2 centimeter macule on the face. She did not have a lesion anywhere else. But the psychological component is so bad that if you don't assess it, you're going to miss the patient. You're not going to treat the patient as a whole. So this has to be kept in mind. And as a resident, don't ignore this part. This will help you in your practice. So treatment options. Segmental and non-segmental vitiligo. If it's non-segmental vitiligo, it's a stable disease. To stabilize the disease, you can use topical corticosteroid and TCIs, targeted UVB. And if there is no response and the vitiligo is stable for a year without cooperation phenomenon, you can go for surgical treatment. If the disease is rapidly progressive with the appearance of confetti-like lesions, increase in body surface area of the depigmented macules, then you can go for systemic oral mini-pill steroids. In early active phases of segmental vitiligo, it's almost similar to non-segmental vitiligo, where you use anti-inflammatory TCS and TCI and targeted UV. Surgical treatment is a preferred option when segmental vitiligo is stable.